with me. Everyone can hear me? So we're going to be talking about 3D today. So feel free to ask any questions you may have. I'm going to start pretty basic with just ultrasound physics and then move into some more advanced 3D stuff. So we'll talk about the types of 3Ds. We're going to focus a lot on neurology because that's the question I always get is how to do this stuff. So you'll see during my talk, I'll have images and not just images of pretty 3Ds, but I'll show you how to get them because I feel like that is what you guys need to learn. And then we'll talk about some case-based indications and why you would get these images. So just to start off, when we talk about valvular disease and especially structural heart in particular, getting a 3D TE is incredibly important. I mean, it's part of our workflow. And pretty much almost every patient will need some sort of good echo, whether it's a transthoracic or TE prior to structural heart intervention. And we now have this new probe. It's the X11 probe. And this is commercially released about a year ago now. So this is the mini TEE. We don't call it the PEDS probe, okay? The PEDS probe is a different probe. It does not have any 3D functionality. The X11 is the new mini TEE probe, and it only will work on the new machine upgrade. So the software upgrades 11.0 or 11.1 is the only machine that is compatible with this new probe. So if you have a patient that is unable to pass an adult-sized X8, then you can use this one, but make sure that you have the new updated machine. So in EP, for example, we had a patient that was going to have a cardioversion, and she had a cricopharyngeal shelf, and so we used the X11 probe, but we had to get the cath lab machine. So just keep that in mind when you're using this new probe. And this new probe I mentioned, it did get FDA approval. It does have 3D functionality on it. And we are lucky to have one here, and I think the OR also has one. So there's two in the hospital, but one for us to use. And comparing it side to side with the adult size probe, it's about 35% smaller. I think the girth is about 6.5 millimeters in size. So it does seem like the PEDS probe. I think that's why a lot of people like to call it the PEDS probe, but it's not. In terms of imaging quality, it's okay. Can you get the lights down, maybe?
That's called damning by faint praise.
Yes, it's okay. So it's not going to be my go-to probe. In all fairness, it's more of I still want to do a TE, but I can't get the X8 probe in. So these are some
probe, or the cath lab had that probe.
So the cath lab bought the probe, so it's in cath lab 6, and so it does have. That's fine.
The lens are really tough
You
here.
want to see the echo? So.
It's like two states.
Echoes stand out now.
So where is it helpful? Again, in patients that can't get the big probe in, I wouldn't make it my go-to probe. I don't think it's there yet. So you can see the image quality. It's, as I said, it's okay. I mean, you can tell pretty good color. You can see color with 3D and 3D on FOS. So if you had to use it, it's in the mid-esophageal views. It's definitely pretty good. Where the limitations tend to occur, in my opinion, is transgastric because you need more penetration than this probe is capable of giving. So you can see on top, the penetration is just not the greatest. So if you're doing a quick appendage rule out or something that you think is going to be mid-esophageal, it's completely fine. You can use this probe. You can do Doppler, color, 3D, anything you need that you would do with the X8 probe, you can do with the X11-4. There is also 3D ICE, which you guys, you may see pictures of it. It's not in our cath lab, but you should be familiar with 3D ICE. The crystals are formatted differently than in the TE probe. So in our TE probe, the crystals are aligned in a grid. So it's a 50 by 50 grid, so 2,500 elements are available for imaging. That's why our images are so crisp. Conversely, in our ICE probe, the crystals are aligned more elongated in fashion, so they're 56 by 15. So you can see that therefore it's much less elements. You only got 840. That's why the ICE images are not as crisp. And also when you're using your angles, so when you're imaging at 90, you're using a lot of the crystals. When you're imaging at 0, again, a lot of the crystals. 45, a lot of crystals. Whereas conversely with the ICE, depending on how you're measuring or how you're imaging, at 0, you're using a lot of crystals, but really when you're imaging at 90 degrees, you're gonna get degraded images because you're only using 15 of the crystals. So that's why for ice imaging, they usually recommend the -45-45 because you're using them at a diagonal and kind of optimizing as many as possible at that time period. So just keep that in mind that no matter how great these 3D phased arrays are on the ice, they're still inferior to our TE probe. The mini TE probe does have the crystals aligned like this in the grid fashion. So the X8 and the X11 are both the same fashion.
Lucy, do you know how many crystals on the X11?
I think it's similar.
Similar,
I think
okay,
it's similar. It may be slightly less. Their oriented fashion, I can look that up.
I'm just
actually don't know.
curious.
I think it's
Because
similar,
it's
but
hard.
not as great as the X8. So when we talk about 3D, one of the most important thing is having a good 2D. So if you have a poor 2D, going into 3D is not miraculously going to just clear up your pictures. You do need a good baseline image in order to get a good 3D. So optimize it as best you can. So gain sector with depth and focus. I can't stress that enough. Use your TGCs and not your total gain control. Decreasing the total gain in your entire image is not going to be as beneficial as if you just are looking at the center of the screen and you can get rid of the artifacts on the top or on the bottom, wherever you feel like you have them. So the TGCs are really helpful. I always try to optimize them pretty much on every image that I have and not just turn down the total gain. Your focus is also important in making sure that you have whatever you're imaging in your focal near zone. Because that's where the ultrasound beam is really going to be focused primarily on. When you image in the far field, you're going to be decreasing your resolution. So if you're, again, imaging a mitral valve and your focus is on the top of the screen and they never touch the focus the entire study, you're really doing yourself a disservice because what you're imaging is not in the focal zone. So you want to make sure that you have your focus exactly where what you're attempting to image. And temporal and spatial resolution, I know that it's ultrasound physics, but it's important to know. Remember that your temporal resolution has to do with your frame rate and your volume rate. And so when you're cropping for 3D, you want to make sure that your sector is as small as you need it to be, or as big as you need it to be, I should say. Your spatial resolution is the number of lines per volume. And so that's where your depth can help. And again, making sure your focus is where you need it to be. So decreasing your sector size will increase your frame rate, but it's not going to change your spatial resolution much. So knobology basics, again, this is more of a hands-on kind of talk. So hopefully next time I give this, I will bring a machine. I thought about it today, but next time. Regardless, I will have screenshots like this for the whole talks to help you figure out what to do. The system interface is a touch screen when it works, and then the bottom part is the system buttons, which you guys all know. Here at Sinai, we have Philips, so I'm going to do a Philips focused talk today, and we're going to just jump right into it. The TGCs, you all know they're here, and this correlates with your screen. So this would be the top of the screen, this would be your bottom of your imaging screen. And so a lot of times when you get the artifacts, they're usually, especially if you're trying to do 3D of the mitral valve, remember that the artifacts usually are the top 2 or 3 rows. It's not uncommon that I will decrease those when I'm doing a 3D on pretty much everything. But make sure that you don't decrease them to the point where you're decreasing the resolution of what you're actually trying to image. The total gain, I pretty much almost never touch unless I absolutely have to. And when I do touch it, it's usually in the stomach to increase the total gain at that point. But usually I use my TGCs if I can for the entire study to optimize my gain imaging. How do you know what you're looking at? If it's snowed out, you're overgained. So if it's all white, you're overgained. At that point, you can turn down your total gain, or you can fix your TGCs on the side. And when you're undergained, what will happen is you'll get dropout. You'll start to see clefts that are not there, or you'll start to see, holes in tissues, perforations that are not there. So it's that Goldilocks in between that you're aiming for. And if you optimize your image before you go into 3D, you'll minimize the risk of either over or undergaining your image. Your EKG gating is important for 3D because it does, if you're acquiring on beats, if there's no EKG, you're going to get chopped images. And so especially in EP, when they don't take the time to hook up the EKGs, ironically, you got to change this to seconds. If you don't have an EKG, then don't acquire on beats. And so that's under your utilities tab. But try if you know that you're upstairs and it's a controlled environment and you're going to be doing 3D, it's a valvular case, make sure your EKGs are good. And you can use your utilities tab and scroll through the leads to make sure that you have one where there's a very clear R wave. And I did that today with, I think, Kyle. I changed it so I saw a very clear R wave because what happens is if it's very low amplitude, then it's not going to know what to gate to. So you can increase the width or the height of the R wave. So there's an EKG gain knob that's next to there that you can increase in order to make it really clear and easy for the computer. EKG gating will increase your frame rate. So it defaults to 1 beat. And you can get really good pictures with just 1 beat, assuming that they're in sinus rhythm. But if you are doing an ICU patient that's intubated, you can temporarily hold respirations and you can increase your beats to up to 4. The reason why I say you have to hold respirations is when the patient breathes, there's going to be cardiac translation, and that will give you an artifact. Most of the time it's a stitch artifact, and I have an example of that on the next slide. But the more beats you have, the more data that is collected for your 3D volume set. So your higher your frame rate, better your spatial resolution, and the better that your 3D will look. Now, most of the work that we do on a day-to-day basis, 1 beat is good enough, to be honest. When you're trying to get volumes or when you're trying to do color or maybe EF assessment, that's when you want to go to 2 beats, or if you can get 4. But 2 beats is pretty easy, especially in someone with sinus. When you're an AFib, I usually don't play with the beats because the R to R variability will decrease or degrade your image to the point where it's usually not helpful. You can see when you change the beats that the picture kind of stalls. And if you see that the picture is stalling, then you're going to have a stitch artifact when you acquire, so don't bother. Does this make sense so far? All right, so here's a stitch artifact. Now this person could have, taken a breath, they could have actually moved, or you could have moved if this was a live acquisition, or it could have been an AF beat. Now this is a 1 beat stitch artifact, and I know it's 1 beat because of the EKG at the bottom. So 1 beat stitch artifact, probably somebody moved, it is my guess. But you can tell how many beats you have by looking at the bottom of the screen. So this is probably either breathing or patient movement or something like that. So this is non-usable information. All right, so we're going to go into 3D. I like to include biplane as first because a lot of people forget that biplane is 3D. You cannot do biplane or X-plane without a 3D probe. And so I purposely say biplane for the record because biplane is gender neutral, whereas X-plane is Philips proprietary. And so here we have Philips, so that's why everyone says X-plane. But really, if you go and give a talk somewhere else, GE will get offended if you say X-plane. So I say biplane. So for the conference, I'll have biplane. So for biplane imaging, it's multiplane imaging. And the first screen that you see on the left would be your main screen. The second screen is usually the defaulted angle of 90 degrees. And I'll get to that in a second. The next option for 3D imaging is a 3D zoom. This is probably one of the most utilized functions for 3D. So it's a wide sector of a small region of interest. So this has a very good, I would say, spatial and temporal resolution, unless you make it too big. Because remember, the larger the space, the larger the sector, the more you're going to degrade your image. And along that note is the 3D full volume. This has the largest sector, the largest acquisition sector possible. So basically, it's almost your entire screen and can have stitching artifacts with this. So this is really when doing the EKG gating in multiple beats tends to be the most beneficial. the other three modalities, I usually, again, don't use EKG gating unless I absolutely need to. And then the last is 3D Live. In my opinion, 3D Live has the best resolution. I actually asked Philips about this once, and they said that it does. And I asked why, and why can't they make all of the other ones the same? And they said because the engineer that created 3D Live retired, and he didn't tell anyone the secret before he left. This is a true story. So this is what we have, so 3D Live, it's whatever you see on your screen. The sector is very narrow, so your elevation width is narrow, and that's why I think the resolution is so good. And it has the most superior temporal and spatial resolutions of all of the imaging modality. Just make sure that whatever you're imaging, because the elevation width is so narrow, is in the plane that you're acquiring, and I'll go through that. So here's what it looks like in terms of boxes. So you can see Live 3D, it's a narrow sector. 3D zoom, it's as wide or as narrow as you want it to be, and then full volume is the big guy. It's pretty much everything. When you get a full volume, you're gonna have to crop into it because utilizing it like that is, again, pretty useless. These are semi-cropped already when you go into them. So biplane imaging defaults to 90 degrees, which is what I mentioned. For a second or third year fellow, what procedure is this?
ASD closure?
What is this? I promised I wouldn't pimp, but this one I was gonna pimp. What is this? So normal or abnormal, first of all? You guys need to come to the lab. Which view? By cables here, yeah.
It's a transeptal puncture.
Someone said transeptal. So this is a balloon, septostomy. Okay, so we're probably gonna be doing like a mitral valve replacement or something. So they're ballooning the septum. So this is a wire, there's a balloon. So we're biplaning this, balloon is going up, and you can see exactly where they are in all four dimensions. So anterior, posterior, superior, inferior. You can see exactly where the balloon is when it's going up. So it's one of the utilities for X-plane. You can see multiple angles at the same time. This is it's 2D windows, but you're getting two windows on the 2D. This is projected off the main screen, and it defaults to 90 degrees. You can change the defaults, and I do that sometimes because if they want to see something a little bit off axis, a lot of times if this is my main screen and they want this one over there, I have to change the angle a little bit, and that would be this rotate 90. So it defaults to 90 because it's 90 degrees from the main, but you can lower it or increase it, and then you can get a slightly different angle. So biplane is not always 90 degrees. So you look at the top, and I'll tell you 50 to 140, that's 90. So if you're reviewing an echo that someone else did, I can look and say, okay, yeah, that was 90 degrees. But you can change it. When it changes, this will turn and change color. So if you're reviewing an echo, you can tell, oh, they optimized, they angle corrected this in order to make it clearer. It's the only time you would do it, or to show something else. So it defaults to 90. This is how you know. This is my starting angle, 0, and you can rotate it here. Questions?
If you go out of biplane and then you
Yes.
enter biplane again, does it default back to 90 or the?
Sometimes
Angle.
sometimes there's a bug and it sticks there, so you gotta check. But most of the time it should default, but a couple of times it did not go back. But the default is set to 90, so it should come out and go back into 90. So if you play with it and you mess up your image and you wanna restart, yeah, just X out and X back in. It should default back to 90, but sometimes it doesn't. And the way you can tell is obviously by looking at that 90, or look up here and see if it's red. Any other question?
And because of the square grid, your biplane in theory is the exact same resolution as your original image. Is that
Yeah, this is the same. So 27 hertz. If I get out of biplane, it should be the same. I don't think it degrades your image. All right. So everyone knows where the X-plane button is, and then keep an eye out for the 90. All right, so sweeps. Is Chris here?
Yeah, man.
This is him. All right, so this is this is Chris today. We did this video together. So sweeps are really important. So one thing about X-plane, before I let this, I can play. When you're in X-plane, if you hit acquire, you can no longer move your cursor. It is acquiring what you have at that 3-second beat or whatever you set it to. But say you want to acquire a sweep with X-plane. The only way to do that is what I am doing now. This was something that was added newer, and Phillips did this because structural heart people were nagging them to do it. So I'm going to restart it so I can show you how to do it. All right, so the first thing you do is you freeze your image and then you unfreeze. When you unfreeze, you are actively recording. So now you can move your X-plane cursor as much as you want, and it can record up to 2 minutes. Then you freeze again, you cine play, select all, acquire. So you will record the entire loop now of moving. This is the only way to acquire an image with X-plane with the moving cursor. Otherwise, it won't work. So I'll play it again because I think it's an important thing to do. And when you're doing mitral valve or tricuspid valve assessments for MR, this is really helpful because I get to see the entire valve in a sweep. So I can freeze it and I can measure leaflet length at any point in the valve. So a lot of times I would, acquire color, turn it off, acquire it, then, put color back on and do it that way, which is fine. It's a manual way of doing it. Takes probably just, 2-3 times longer to do it that way than this way. But this is nice because you're recording the entire valve. So to do it again, you freeze, unfreeze your image. Now you're actively recording. You sweep through with your X-plane, as you can see me doing on the left, until you get to the point where you want to stop recording. You freeze it, cine play, select all cine, and acquire. Right?
Can you do this with color too?
Yes. So I have a video with color, but I didn't put it in because of time. But same thing. The only thing that, though, when you have color up with X-plane, there's 2 ways to do this with color. The first way is to do this exact thing, but when you freeze and unfreeze, to be able to move your X-plane cursor, you have to select cursor from the bottom menu from here. So the tilt is automatically selected when there's no color, but when there's color selected and then tilt. So you actually have to hit the left kidney beam to select tilt and then move it over. So you freeze, unfreeze, left kidney beam to select your X-plane cursor and then scroll through, freeze, and then it's the other steps. The only way to not do that, because people always get flustered when they have to do this left kidney beam, is if you zoom in. So if you zoom in onto the valve with color, then it's the exact same technique. It's a workaround. Any questions?
We just
Yeah.
just have to be on X-plane, biplane when we do that freeze unfreeze. We don't have to pre-select anything
Yeah,
like
that's
cineplay.
it. Just
Free unfreeze
X-plane.
and then later you do cineplay after you've done your sweep.
So you cine play, select all,
Just like
acquire.
Yeah.
If you cine play, acquire, you're only gonna get
whatever.
the last 1 heartbeat.
Okay.
So you have to do all and then acquire.
It's my understanding that for what you were acquiring in general,
Yes.
it is putting all the images into some sort of buffer. So that when you freeze, you can use the trackball to go backwards.
Yes.
But it's not forever, but it goes for a fair time. If you then unfreeze, you've lost and you're starting from 0.
Yes. And the key for this that makes this a little different is the fact that this with X-plane, if you hit acquire and you try to move this, it won't let you.
Okay.
It won't move because it's acquiring.
Yeah.
When it's done, you can do what you said, but it's only at this one spot in the valve. If you want to acquire a sweep, the only way to do it is this technique.
Thank you. How long is it? 2 minutes? You
Up
said
to
that?
2 minutes, so you can take your time, no need to rush. I usually move it, wait 1 or 2 cardiac cycles, move it, 1 or 2 heartbeats, move it. So then you get, systole, diastole in multiple stages. So cine play, and then after you click cine play, select all, and then acquire. All right, so live 3D is next. So remember atrial septicemia? So if you click live 3D, it will show you 3D of the exact image that was just on your 2D screen. So remember that this image will mimic what was on 2D, but you're acquiring this 3D image set at a very narrow elevation width. So if you want to then say, oh, I have the aortic valve in here, let me just measure an aortic valve area. You can't, it's cropped out. You can't measure a mitral valve area. You can't measure a tricuspid valve, anything, because it's only this little sector of 3D that you got. That's why, one of the reasons why the image quality is so clear is because it's such a narrow elevation width. But any 3D image you see, it will be labeled what it is on the screen. Also take note that this is a 4B acquisition, this live 3D, even though I don't have a heart rate, I think it's because the ECTB, but this was a multi-B acquisition. And it's gonna acquire what you automatically have saved on your machine. It's not like a 3D zoom where you can change it. It's whatever is already pre-programmed. And then the live 3D button is here. So it's the only 3D button that's on the bottom part of the machine. The other ones are touchscreen. 3D zoom is probably our workhorse for 3D. I think we use it the most, in my opinion. Again, every 3D image will have it labeled, what you use to get it. Also, you can see how many beats were acquired. This is a 2B acquisition probably. And then you can see here that this is surgical view mitral valve that was acquired with 3D zoom. And so right next to the 3D zoom, right next to the live 3D, there's this dual button. So this dual button will work when you're in 3D to show you whatever your index image was from both sides. So this was a surgical view. And so now I'm looking left atrial down at the valve and also right ventricle up at the valve in the same image. This is incredibly helpful for prosthetic valves. I use dual view a lot in the surgical view to look at the valve from top and the bottom simultaneously. Remember that when you are doing this, if you're going to be dual viewing the mitral valve, your TGCs need to be adjusted. Now, we already know that in the surgical view, the top 2, maybe 3 rows of your TGCs, you've already turned them down to get rid of any left atrial artifact, right? We do that pretty routinely. But what a lot of people forget to do is to turn down the bottom 2 or 3 rows, because now you're looking from the bottom up on the valve, right? So you need to crop out all of the subvalvular junk. So whether it's chordae, calcium, PAPs, you want to see the valve. So you need to crop those out, and you do that with your TGCs. When you do that with your TGCs, you can look for halts, or you can look for pannus overgrowth, right? That wouldn't have been visualized unless you cropped it out. So you got to optimize your TG, and then don't forget to put them back because you need them for the rest of the study. But so here you probably cropped out the first 2 or 3 rows and then the bottom 2 or 3 rows. You left only the center part of your screen. You can see the valve both sides, and you can see that there's pannus overgrowth here. That's what's causing this restriction. Great. Questions on that? All right. So 3D, this is still a 3D zoom, but it looks different. And that's because we're changing the display. So this is True View. True View will basically just change how the image looks by changing the display. It does not change the frame rate. It does not change the spatial resolution. It just makes it a different color. In my opinion, it is helpful for prosthetic valves and for LAAOs. Otherwise, I really don't know the utility for this. What you can do is on your touch screen portion of your console, if you touch different parts of the screen, you will be moving a light source to look at it from, like a spotlight, to be looking at it from different angles. And when you move the spotlight around, you can see perception of depth. So why I like it for prosthetics is because if there's a PVL, you want to see, how is it leaking? Is it a serpiginous root? If you're putting in a plug, or if there's a Watchman's shoulder, those are things that you kind of need to understand, is the perception of depth in those situations. That's when I would use TrueView. Otherwise, I don't really find a utility for it, but maybe that's just me. So this can be done post-processing as well. So you don't have to do it live. So if you get one 3D image and 3D zoom and you move on, and at the end of the study you're like, oh, I really wanted a true view of that valve, just go back to that image and change the display and you can reacquire it, and you can do that. It does not have to be done live as long as you have a 3D image. That's basically what I said. It's the same color, or it's the same exact image. It's just true view and regular there. Nothing has changed. The frame rates are the same. Everything is the same. It's just a different color, different display option. However, color is different. So whether it's true view or regular with color, you will see a drop in your frame rates when you turn on color. So that is not different, or that is different, excuse me. So make sure that your box is only as big as you need it to be for the color. You will drop your frame rate, the resolution will go down. So utilize this, you know, get the best 2D you can and then turn on your color. You can use TrueView, I guess, also to look for clefts, but to be honest, you can do it with regular 3D as well. Remember, the definition of a cleft is that when you see a deep indentation in the leaflet, both sides. So if I only look at it on this side and I see something, until you turn it around and prove that it's going all the way to the base on the back side of it, so use your dual view or flip it around. It could be a fold, especially in very myxomatous valves. You know, if they fold, it could look like a cleft. So you want to see it open, you want to see it from both sides if you can, and you want to make sure that it goes down to the annulus, especially from the bottom side. That's how you know the difference between a fold and a cleft. So 3D is really helpful. 2D, you really can't tell these clefts very much. You'll just see that there's dropout and you don't know why. So 3D is pretty superior on that. Glass view is this technology. You can hit glass on a 3D. Again, it's similar to TrueView in terms of frame rate, resolution. Nothing will change. This will not, you know, need to be acquired in real time. You can do this also post-processing. So if you have a 3D zoom mitral valve, that's it, and the patient's in recovery, you can go back, you can put on glass, you can put on dual, you can do all this post, and it's okay. Any questions? So how do you get the best picture? Well, cropping, and especially if you have a full volume, you're going to need to learn how to crop. And so for a majority of the talk now, we're going to be talking about cropping. So cropping can be done either before or after. Every time you 3D zoom, you're cropping because you already cut out what you need, right? But let's take it a step past just 3D zoom. Remember, only make the box as big as you need it. The bigger you have, you're decreasing your resolution and frame rates with unnecessarily. So multi-view is what we use in Philips in order to crop. Multi-view is not NPR, okay? Multi-view is not NPR. They may look like they could be, but it's not. They're two different things. So multi-view is what we use to crop. It's the cropping software. Once you're in your 3D, data set has been acquired, and then you can go into multi-view here. Multi-view on the 3D tabs. Now, multi-view has its entire own, I guess, page, you can say. And we're going to go through each section of this stage because I think it's really important to learn how to crop. And so when you're in the multi-view menu, there's a couple of important sections that you need to understand. The first is the layout section that's here. So this is a display. This is how do you want your images to be displayed. Single, 3x1, 3, 4, or even you can even do a grid view. So that's the layout section. The second section is the reference planes, and I'm going to get into a lot of detail with that. And the last thing I mentioned, but the most important thing, is the lock planes in the middle. So the lock planes are something that I wish they would default to be locked, and I asked them to do this, but they don't know how. So the first thing you do is lock your planes. Immediately lock before you do anything. You enter multi-view, you lock your planes, because at least then you know that you're not going to be measuring at diagonals or misshaping your planes. I think especially for beginners and even advanced people, the first thing they do is we lock our planes. So this is our display options. This is not NPR, this is multi-view. So this is the single image, 3x1, 3, 4, or grid. So once you get your 3D data set, you can just show the display any way you want. And so there's utilities for all of these. You know, you may ask, you know, when would you use one over the other? Well, we like this one because we like things big. So when we do surgical view, we like to do this one. But if you really want to know multiple angles at the same time, you may want to do the 3x1 or even by 4. This one's really helpful for Mac. I think it's underutilized. I think if there's a lot of Mac, especially since you're trying to figure out the multi-level extent of mitral annular calcification, use the grid screen because that by default will show you multiple levels and you don't have to do anything. It's cropping through the valve for you. And I know that it's hard to see, but there's multiple dotted lines here going through the valve, 3 in particular going through the valve, and they correlate with these planes. So you can actually move this up and down to make sure that you're cropping through the valve, and you get 9 images through the valve without even doing anything. So this is changing your display, and again, that's pretty helpful for Mac. So the multi-view planes, I'm going to show you how I crop. There's a lot of ways to crop, but I'll show you my way, and you guys can modify it to be your ways. But so the reference planes are the green, red, blue, and 3D. And they correlate with the green, red, blue, and 3D on your display. And so when you're cropping an image, so you have your 3D open, you decided now I want to use my multi-view planes to crop. At this point, you are now using multiplanar reconstruction. You are reconstructing this valve to make it look like what you want it to do. So there's 2 main buttons that you need to understand the difference between. One is the rotate Z, and one is the rotate GB, or this could change. We'll say with rotate GB for now. And I'll explain what the difference is. So rotate Z is what you see here. So you're in the 4-grid box, and I have selected red. That's why red is highlighted. And that's why it says here, it says rotate GB in red. Okay, but what I want to do is rotate Z. What happens when I rotate Z is I'm rotating the red box, because that's what's selected, on its Z axis. So the entire image is going to turn. This is different than the crosshairs. The crosshairs are not moving. Rotate Z will turn the whole image. If I would have selected rotate GB, then I would move the crosshairs. Okay, so rotate Z is I use it in the lab specifically to stand up my valves. So if you have a horizontal heart, you see how this annulus is kind of sideways? It's not straight. So a lot of times that I see is like the valve straight up and down, just so they can imagine it better. So I would rotate Z just to stand up the valve. I'm not changing the anatomy, I'm not doing anything, I'm just showing them a different way to see things, to stand up the plane. Sometimes they ask to stand it up. That's what they mean, rotate Z. Rotate GB is an option because I have the red reference plane selected. So I am working in the red box. This is the red box. Since this is the red box, the options in here are to rotate the G and the B. So these lines can turn. And that's what you see here, or what I'm trying to show. So that's how you rotate those planes. So when I crop an image or when I orient, say I'm doing a mitral valve area, I like to do the red box first, then the green box, and then the blue box. That's just how I was taught, and so that's how I teach now. But it makes sense to me to work, counterclockwise. Whatever image is, or whatever plane is selected as your reference plane, again, this is red is selected, that's what my 3D will match. So if I want this, we like to have the short axis of the mitral valve as the 3D, then you just have to touch blue because this is in the blue plane. If I touch green, then my 3D will match whatever's in green. So whatever is selected as your reference plane is what your 3D will match. And you can't lock it. Like say you always want it to just, you can't do that. So this is the red. When I have green selected, now green is selected. Notice that now it's in green. Rotate red, blue, because now in my green plane, the planes here, the crosshairs are red and blue. So that's why. So they put it green in color because we're working with the green box, but the planes that we're adjusting are the red and blue. So that's why it's RB. Okay, so I'll rotate the green box to wherever I want. And my goal is to have the blue, for this particular example, my blue is going to be at the mitral valve leaflet tips because I'm trying to measure a mitral valve area. That's what I'm trying to do here. So you can see that I'm going to rotate this one so I get that posterior leaflet in and the anterior leaflet in. And then finally, my last step is the blue. So once blue is selected, blue is special. Another reason why I always do blue last is that, yes, you'll see the rotate RG because those are the crosshairs on the blue. But this plane adjust button will now appear. This plane adjust button will not appear in any other window except when you click blue. Remember, once I click blue, my 3D will match the blue. But now I'll have a plane adjust. So what is the plane adjust? The plane adjusts are these dotted lines, and that is your cropping line. So remember, I always use the example of this is your platform. Okay, so that is where you're standing on, looking down at the valve. I know we're looking down because there's down arrows, you see? I can flip crop. I can flip this line, and I'll flip it down here. And then it'll look up at the valve. So then the arrows would look up. So it's important to see where the line is and where it's pointing because you can actually manipulate it. So if I was looking for pannus overgrowth on this valve, instead of doing, the dual button on my kiosk, which is not available because I'm in multi-view, their workaround is to do this plane adjust. You can flip crop and look up at the valve. Any questions?
Yeah, what do you push to make it flip? Like
On your console, I don't have an image of it. There it says flip crop
on the touchscreen.
touchscreen on the right. Yeah. Okay. Oh, here, flip crop. I do have an example. So you can see here, that's what it would look like, okay? So you can see the difference. It's a subtle change, but really I'm looking, left atrium looking down at the valve, left ventricle looking up at the valve. It's great for pannus, great for halt, great for trying to figure out what's wrong with the prosthetic valve, if anything. All right, so NPR, multiplanar reconstruction. It's you get a 3D volume set and you're able to look at the data that is inside that volume set from different perspectives without moving your probe. So it's really convenient for people to decrease trauma to the throat. Like you're not manipulating it too much. Once you get one really good picture, you can really crop into it and get the data that you need. It's similar to CT in the fact that they get coronal, sagittal, and transverse planes, and you end up getting with similar planes on your NPR. So let's see, when would you use some of this? So this is a patient we had last year, and they had an Alfieri stitch, and they were sent to structural, and they're like, can you clip this? Well, you can see the stitch. You can see that's leaking just lateral to the stitch. You can see it from the LV side up, and, I don't see any posterior leaflet here. It's hard for me to see. So you can't clip if there's no leaflet. So the only way you can figure this out, because 2D wasn't helpful, is using NPR. And so that's what we did. And so when you're in NPR, you can sweep through the valve just like you would on the 2D sweep, but you can sweep through the valve with your NPR. And so we moved it over to where it was leaking, so around the A1, P1. And sure enough, you can see that there is posterior and anterior leaflet there. But it really wasn't appreciated, and you don't know exactly which level you're at unless you sweep through with NPR. So this is one of the best ways to sweep through a mitral valve because it will give you 2D and 3D simultaneously. So I will know exactly the orientation of where my clip should be and the exact image at that location. So I'll be able to freeze frame, measure, do whatever I need to, and say, yes, this patient is clippable. We did clip this patient. They had an excellent result. So, a very good use for NPR. If you are doing a mitral valve case and you meant to sweep through the valve, but you got distracted and you forgot to get those key images, but you have a good 3D, you can go back and post-process that 3D to give these images. And so then you can show the person who's requesting the echo, okay, this is the leaflet length. Sorry, I forgot to get it in 2D, but I got it in 3D. We've done that a couple times. Questions about this? So the way to do it, when you're trying to measure, for example, also residual valve area, we also get asked this after a mitral clip. You can use your NPR crosshairs to measure exactly what you need, so medial and lateral orifices here. And again, you just line it up with what you think the leaflet tips are at that particular point, and then you trace through. Building NPR, I went through all the steps, but I'll show you. We made this video. It's, I think, 25 seconds long, so it shouldn't take that long. And it's for teaching purposes, so it's a little slower than what we would normally do. So you can see here, I got my 3D. I locked my planes. First thing I did, I'm rotating red, green, blue to surgical view. And then now I am tracing. So measure and then trace. So 20 seconds. It really shouldn't, and that's when you're doing it. You don't have to do it in real time. You could post-process it, but it really shouldn't take you longer than that. I'll let it play again because I was chatting in the beginning. So 3D volume was obtained. That was a 3D zoom. Freeze frame it. I always freeze it before I try to measure. So freeze it open, lock your planes, right click to get your crosshairs where you want it to be. Rotate red. Green is good. And then rotate blue. I know I selected blue now because my prop plane is up there when it's a 3D. And now you do your direct measurement at the leaflet tips. You could do the same thing with color. When you're trying to do this fast and repetitively, for those of you that end up doing structural at whatever institution you go to, I just want to educate you that there is a 3D home button. So you can save home. And so like say, okay, 20 seconds, but I don't have time to do 20 seconds. If you do it at the beginning, it's that like patients intubated, you're getting a Watchman or something done, or they're doing a mitral clip, you have 20 seconds in the beginning of the case, you can set up your planes and hit 3D home, which will save your planes for you. So you can come out of 3D, you can do whatever you need to do. Then once you get your 3D volume set later in the case, you can hit 3D home and it'll take you automatically back to your settings. So it's a fast way to recall all your settings. There's some flaws in it, but it really works fairly well. So sometimes we do that. Like when we do our symposium in December, I do that because it's fast and I don't have time to manipulate it. So I usually set my homes before we go live. So then when we go live, I can crop it quickly. NPR has limitations. There is a learning curve. So you guys practice when you have time. And a lot of the things I showed you can be done post. So if there's downtime in the echo lab and we're in between cases, just go to the machine and pull up a study and practice. That's really the best way for you to learn. I learned in the ORs. I did that in the ORs. I would go and just practice in the ORs. And so take advantage of the technology you have here. If it's a slow day in echo and there's a machine available, practice. Be careful of the artifacts. Learn how to set your gains. Some of that you can't do. Like if the image was acquired wrong, like you can't post-process the image better. But if you have a really good 3D image, you can post-process that. We still have time, right? Okay, just quickly, 3D EF. is something that you can use the 3D volume for. Now this is something that, I don't know if you noticed, but my frame rate is 49. So this is a 4B acquisition. This is done in the OR with breath hold. Usually upstairs in the lab, you can get to the 20s pretty good with 2 beats. And that's all you really need. You don't need a 49 unless you want to give a talk about it. But this is really good high resolution. There is potential for error in some of these EFs. We have TomTech now, so if you acquire that 3D image, you can go into your TomTech and get your 3D EF. You can also get a 3D strain. So you would just follow the prompts that are on. So it would be, it's called LV4D, I think auto, or analysis, sorry. 4D LV analysis is what the option is to get into this system. So you click on your 3D image, then you click into TomTech. It's going to open up the TomTech window. Once you're in TomTech, you find your 3D image, you right click on it, and you go 4D LV analysis, okay? And that's what you'd get here. This will have steps on the side, 1, 2, 3 for this exact, and you just follow the prompts, and it'll tell you how to do it and how to get your 3D EF. The last one is also a 3D strain. Just be careful which one you're picking because there's options, because there's tangential strain, radial strain, longitudinal strain, they're all options. So make sure you're picking the longitudinal strain if you're going to be using this to report. And you can get your peak to time to peak. So if you're doing a mechanical dispersion case, like someone has prolapse, you can do that. You can do EF on here. This patient had a really bad EF. It was that same patient I showed you before. So some caveats, you really do need a good picture for 3D EF, and if they have scarred ventricle or thin walls, usually that can cause some problems. So make sure that you can get the best acquisition possible. So use your multi-beats. This is when you would use multi-beats, I think, is the 3D EF. Briefly, I'll talk about auto mitral valve. This is still experimental. I don't expect this to be reported out anytime soon, but we have it in our system. So if you see it, just know what it is, I guess. The MVN is this software that they installed. It's also an automatic software. Once you get your 3D volume set, you can scroll through and it will give you things like annular dimension, like leaflet angles and tenting heights and all these things that are not clinically useful. So I think they're still trying to figure out what the utility for this is. I tried to use it to get a mitral valve area, but it's just not there. In my opinion, it's so much buttons and it's just not there yet. But using what I taught you with the NPR, I think is more helpful. They have also the same thing for auto tricuspid valve. To be honest, I think this is a better software package than the mitral package because for patients who are getting evokes, we really need to know the tricuspid valve annulus. And because the annulus is easier visualized than the leaflets for the mitral, I think it gives more accurate data. And I did a couple cases side by side where I would measure and then I would do the package to measure. And the package measurement was close to mine and close to CT. So I actually do believe in this one, but it's still pretty new. And I think they just installed it like, I don't know, like 2 weeks ago, so I haven't used it upstairs yet. For this to work, you do need higher frame rates, so at least 20. And just briefly, future directions. I think Philips is doing a great job with their technology. It seems like every 2 to 3 years they're coming up with more and more upgrades. The next upgrades that are going to be coming down the road are auto measurements. So auto vena contracta areas for 3D and auto mitral valve areas and things like that. But really the regurgitant volume and the EROAs automatic with 3D once you have a 3D color. That's coming. You didn't hear that from me though, but that's coming. And then they're trying to integrate it with other like virtual reality stuff. But I don't. So in summary, 3D imaging, it's pretty awesome. I think that it's not anymore something that's nice to have on your echo. I think especially now that we're doing these structural procedures, it's more mandatory. And so, you know, practice when you can, especially if you have a free machine, and I'm here to help with any questions. Any questions?
That was great, thank you.
Thank you guys for
It was very
coming.
nice. Nice job,
Lucy.